May I kindly request Hiramani sir, General Secretary of this hospital, to present the token of love to Dr. Purshotham. Again, I request Hiramani sir to present token of love to Dr. Sagun Joshi. Without further delay, let's move on to a scientific session. Our first scientific session today is graced by esteemed experts from ORS team with various subspecialties. Our first speaker of this session is Dr. Ronald Gently. He is a clinical professor of ophthalmology affiliated with NYU Langone Health, New York Eye and Ear Infirmary, and Sony School of Optometry in New York City. He is a retina specialist and surgeon. Dr. Gently has been consistently listed as one of the best doctors in New York, recommended by his peers. He has received dozens of awards and honors. He is past president of the New York Academy of Medicine Ophthalmology section and continues to be active within organized medicine. He has been a mentor to hundreds of young doctors, pre-med students, ophthalmologists, and optometrists, who he has helped train on both the art and science of medicine, surgery, and eye care. Let's welcome Dr. Ronald Gently.
Thank you very much. Before I get started, I'd like the residents and fellows to raise their hands. Do we have any residents or fellows in the room? There must be more. Where are all the residents and fellows? Come on, raise your hands all the way up. 1, 2, 3, 4, 5, 6, 7, 8. So I want you to come a little bit closer to the front of the room. Come on, I want you to stand up. There's some seats over here because I really want you to get a good look at some of these videos. The other thing I want to mention is how lucky you are to have the leaders that you have. Ophthalmology is a team effort that requires leadership from those that have trained before us. And I could see that your foundation here is pretty admirable. This is a fact here, just from the speeches that I've heard with Professor Sasank, Professor Chet, Professor Joshi, and you can see some of the young attendings here that have the same mission that their predecessors have. So I want to congratulate you for that, but I also want you to think about taking on some leadership roles in your lives as you start to get better training to take on those that are younger to actually support your country, because this is a beautiful country and I'm really grateful that I'm here and I really appreciate your hospitality. So to get on with my lecture, I'm going to talk a little bit about posterior segment trauma and surgery. I'm going to start off talking a little bit about trauma and its classification and show you some examples. And then I'm going to show you a very interesting case, a surgical case, of how we manage an open globe injury from beginning to end. I don't really have any conflicts of interest for this lecture. I mean, I am a PI and sub-PI for multiple clinical trials. Just to let you know, if anyone ever asks you about ocular trauma, this one fact you have to remember. It is the leading cause of monocular blindness. Now, in the United States, there's 2.5 million eye injuries per year. But if you go worldwide, because we have 8 billion people in this world, we have about 1 million eye injuries worldwide. And that's important. And I would probably have to say that depending on which country, the eye injuries are going to be different. And in some cases, more devastating. This is something you have to remember. This has to do with the classification of mechanical eye injuries. And you have to understand that there are closed globe and open globe. And you can see they're divided into contusion, superficial foreign body, and lamellar laceration for closed globe. And for open globe, it's divided into laceration and rupture. But laceration is divided into 3 others: penetrating, intraocular foreign body, and perforating. One of the things you have to know is the definition. The definition of a closed globe injury is no full thickness wound of the eye wall. And when we talk about the eye wall, we're not talking about the choroid or the retina. We're talking about the cornea and the sclera. So a full thickness injury to the sclera or the cornea is considered an open globe injury. Why is this the case? And even though the eye wall has 3 coats, it's the cornea and sclera that have the integrity of the eye. And once that's penetrated or ruptured, that's going to be an open globe injury. So in your mind, there are cases that we see. So this is an example. And this patient comes in, had some superficial trauma to the eye. Is this an open globe or closed globe injury? Well, this is easy. Not a hard case to determine. This is a closed globe injury. There's no full thickness wound of the sclera, and there's no full thickness wound of the cornea. Here's another case that comes in. Is this an open globe or closed globe? And here you can see a full thickness laceration of the sclera, so it fits our definition. You can see uvea. Relatively easy diagnosis, right? Open globe injury with sclera that's been involved. But not all cases are like that. There are cases that come in and they're not that easy to diagnose if it's opened or closed. Oh, here's a case of a patient, airbag injury. You can see subconjunctival hemorrhage. And if I ask people in the audience if this is open globe or closed globe, I just want to remind you this is a trick question. So is this an open globe or is this a closed globe? Any of the residents want to comment on that? Good. Good answer. All right. Well, this patient actually had an airbag injury. Pressure was 4. You can see the pupil's a little bit eccentric. This looks like an open globe injury. You see the subconj hemorrhage. You're thinking maybe there's a laceration. Actually, this patient ended up having a cyclodialysis cleft, and on exploration had no full thickness wound. So this ended up being a closed globe injury. And I'm going to show you why I'm bringing this up. Here's another case. Here's another case of a patient that fell. This patient here had an open globe injury. So there are cases that come in, and we're going to say, is this open globe or closed globe? It's okay to use the diagnosis of rule out open globe. Right? So doctor gets on the phone. Is this an open globe or closed globe? Well, I think it's rule out open globe. And you give all the data that you need to the professor or the person or attending to sort of explain that. Again, let's go back to our classification. And I'm going to put in this classification. I'm going to add in rule out open globe. Now, I didn't publish this. I just put this in there because I think this is important. Because a lot of times you feel the pressure to know what the exact diagnosis is when you see the patient. But on those examples that I showed you. Closed globe injuries, okay? I just want you to know them. I have a whole separate lecture that takes quite a while, but I'm really going to focus on open globe injuries. And again, I mentioned to you there are 4 types of open globe injuries. There's the rupture, there's the penetrating intraocular foreign body, and the perforating. Now again, when we go through these types of injuries, this is what the definition is a rupture is related to a blunt object that increases the pressure of the eye, and it's what we call an inside-out mechanism, where there's a rupture based on the pressure that increases in the eye from a blunt object. A lot of times what you'll see happen is every open globe injury, and this is true in the United States, the resident calls you up and says, I have a ruptured globe. I have a ruptured globe. I said, well, what was the mechanism of injury? He got stabbed. I says, well, then it's not a ruptured globe. It's an open globe, and it's a laceration. So knowing these definitions are important. You can see that in a rupture, the location is usually at the weakest point of the sclera or the cornea. If it's the sclera, not uncommonly, it's posterior to the muscle insertions where the sclera is the thinnest. If there's an old cataract wound, it could happen at that wound, at the limbus. Or if there's any other area that may be thin, where that area of thinnest portion and the weakest portion of the eye wall will actually rupture. In terms of laceration, it's usually caused by a sharp object. And remember, we said before what a rupture was. It was an inside out. This is outside in. This is something from the outside that's penetrating into the eye. If it's penetrating into the eye, but doesn't go far enough to go outside the eye, and there's no foreign body within the eye, that's called a penetrating injury. And you can see the differences here in terms of penetrating injury. The entrance wound is without an intraocular foreign body. Now again, remember we talked about rule out ruptured globe? Again, these cases, when they first come in, you may have rule out intraocular foreign body. You may suspect it's a penetrating injury, but if you're not 100% sure, then you might have that diagnosis, which might change. In terms of intraocular foreign bodies, we treat them differently. Even though it's a penetrating injury, it's when the foreign body actually remains within the confines of the eye wall. And the way you should think about this is, why did this intraocular foreign body stop inside the eye? If the kinetic energy of this foreign body was great, it would go not and stay inside the eye, it would exit out the back of the eye. What type of injury is it if the intraocular or the foreign body enters the front and goes out the back? What type of injury is that called? Any of the residents want to take? Perforating. So that's the way you should look at it. And again here, with a perforating injury, the entrance and exit wound, both wounds are caused by the same agent. If you look here, there's one special injury that I've seen that's not on this classification. And I call it it's called the explosion injury. It happens when someone actually injects inside the eye and causes the eye to rupture. Remember we talked about a ruptured globe compressing the eye? This is from injecting in the eye and then the eye exploding at the weakest point. This is not on the mechanical eye injury classification, but I want to add it here. In my career, I've only seen maybe 2 cases, and I've operated on 1 case. And you can see here, just so that you know that this is possible, this is, again, a very hard diagnosis to make unless it's known, because it's usually a complication of the peribulbar or the retrobulbar injection. And you can see here, here's a publication of this rare open globe injury, and you can see the visual acuities for most of these patients are very, very poor. So I wanted to add that to our classification. In terms of open globe injuries, you know they come in zones, and I think you really have that down. There are 3 zones. Zone 1 is involving the cornea to the limbus. Zone 2 is involving the limbus to 5 millimeters posteriorly. And then zone 3 is posterior to 5 millimeters. Now, many cases may involve more than 1 zone. The way we classify it is, it's what the most posterior zone is. So if the cornea is involved, and then the limbus is involved, and it goes behind the muscle insertion, that's going to be zone 3. So let's go through this, okay? Here's a case that comes in, all right? Is this a rule-out ruptured globe, or do we think we got this one? So what is this? Is this an open or closed globe? Open globe. I'm going to tell you that the mechanism of injury was a bar fight. I know you don't have a lot of these here, but they do have them in New York City. And a bottle went across his eye. So what type of injury is this? Penetrating. So I'm going to say that it didn't go out the back of the eye. Now, do you want to know how far that posterior wound goes? Okay, so the posterior wound goes 3 millimeters from the limbus. So what zone is this? Let's go back. Zone 1 is involving the cornea to the limbus. Once it passes the limbus, from the limbus to 5 millimeters, it's zone 2. So this is zone 2. Why is these zones important? Because in your mind, you should remember that if zone 3 is involved, that's where the retina starts. You know you have retinal involvement. In terms of how we manage these open globe injuries, okay, I call this external reconstruction of the globe. And really what you want is you just want a watertight wound closure. If you have to excise some uvea or reposition it, that's an intraoperative decision. But you really just want to get a watertight closure of the wound. Now, I'm going to show you an example of an open globe injury. And you can see here, we really want to expose and get the sclera and suture sclera to sclera. And you could see here, getting sclera to sclera is the most important thing. And I'm going to show you this case in more detail from the beginning to the end. We have something after the primary repair, we have something called a secondary repair. And the secondary repair, the way you should look at it is, it's internal reconstruction. That's what retinal surgeons are best known for. They go inside the eye and they start repairing the inside. So patient comes in, open globe injury, we repair the outside. Now this is internal. And this can consist of many different parts: cataract removal, ciliary body, retina repair. And that's how we're going to sort of look at it, is primary repair and secondary repair. Now, what's the timing of primary repair and secondary repair? Well, in cases, the secondary repair sometimes is performed at the same time as the primary repair. And this usually occurs if there's an intraocular foreign body. We know that because we have to go inside and repair it. Or if there's endophthalmitis. Otherwise, you can just do the primary repair, close, and then refer, and have that surgery, that secondary repair, delayed. There's two ideas. There's the early and secondary repair, and then there's the delayed secondary repair. Okay, some surgeons prefer to do it before 3 days. In my experience, and a lot of other surgeons, we like to wait at about 7 to 14 days to start to do our secondary repair. And the reason for that is when we go inside the eye, we really want the cornea to have its best ability to actually see through it. And also the surgical planes become easier to identify if you wait, because young patients can tend to develop posterior vitreous detachments. Choroidal hemorrhages could actually liquefy where they're easier to drain. So in my hands, I usually do a delayed secondary repair. There are advantages and disadvantages to each, okay? With the delayed repair, sometimes there's less bleeding, a vitreous detachment may be present, the choroidals may have resolved, and visualization is better because the cornea has cleared. People feel that sometimes doing it early, there's less surgery and less scar formation. There are exceptions, like I mentioned before, infection and intraocular foreign body. And I just want you to know that there's also exceptions for late secondary repair, especially if there's a choroidal hemorrhage that you want to give more time to liquefy. This is an example of internal repair, right? I showed you the external repair. and I showed you where the scleral wound was sutured. Now I am looking at the scleral wound from inside the eye. So you see the vitrectomy is occurring, and I'm repairing that area from the inside. So I showed you a video repairing from the outside, putting sutures in. Now I'm showing you a video repairing from inside the eye. I'm going to show you a few little examples here. This is a patient that came in, and take a look at that. Look at the lens, and then look at the transillumination. You see there is a peripheral iridotomy. This patient's 30 years old, was working with some drill, and never had any history of surgery. What are you thinking? Right? So if you look a little bit closer, you could see here, this is an open globe injury. Right? And then when you look in the back of the eye, you can see there's an intraocular foreign body. Remember, if the kinetics of this intraocular, if this foreign body had higher kinetics, it may have exited out the eye. It wouldn't be an intraocular foreign body, it would be a perforating injury. One of the things that you have to be aware of is that the CAT scan is the best way to identify an intraocular foreign body. MRIs are contraindicated, and you know that because some of these foreign bodies are metallic. And X-ray is usually not good enough and misses many intraocular foreign bodies. And this is just showing, be aware of the plain film. Again, endophthalmitis, devastating, 7% of open globe injuries, just to be aware of it. There's one type that I want you to know, okay, of post-traumatic endophthalmitis, and that has to do with this organism called Bacillus endophthalmitis. Right? This is one of the most endotoxin-producing bacteria that you'll ever see. Within 24 to 48 hours, the eye will become inflamed, hypopyon, and you get necrotic tissue. So just to be aware of that with intraocular foreign bodies, that's why many places, if there's a risk of bacillus, they'll give intravitreal injections if the surgery is going to be delayed for an intraocular foreign body. Again, if there's delayed removal of the intraocular foreign body, patient may not have many symptoms or may not come in, and you probably see that here, maybe quite often. Be aware of the heterochromia in these cases where they have intraocular foreign bodies that have been missed. And you can see here just showing an example of the ERG changes that occur, that the ERG becomes flat. And you'll see other clinical indications of a non-reactive pupil, iris heterochromia, cataract. And again, leaving intraocular foreign bodies, you get siderosis. It causes a pigmentary retinopathy, optic atrophy, and even glaucoma. Retinal detachment after open globe injury. People always, this is a very feared complication. One of the examples we saw at REMEH was a case of an open globe injury that ended up with a retinal detachment. They're not uncommon. The incidence is about 29%. If you look in terms of when the retinal detachment is identified, okay, you can see that about 72% are identified within the first month, but there's not about 27% within the first 24 hours. So be aware of any open globe injury. If you can't see the retina, there's a high incidence retinal detachment, we want to pull out our B scan. There are risk factors for this, and we discussed that before. Remember, we said that the zone 3 is going to be involving the retina. Well, if the retina is involved, there's going to be a higher risk of retinal detachment, and you can see zone 3, vitreous hemorrhage or poor initial visual acuity is a risk factor for retinal detachment with an open globe injury. And you can see here, this is showing you more examples of what that percentage is. And you can see based on visual acuity, intraocular foreign body, penetrating injury and rupture. And if you look at the incidence of retinal detachment in the 4 types of open globe injuries we discussed, you can see that perforating injury is about 55%, is the highest. People have asked, do we put a scleral buckle on a retinal detachment or an open globe injury that has a retinal detachment? And for the case that we did at REMEH, we did put a scleral buckle. There's not a lot of data out there. The question is, should you put it on at the time of the initial primary repair, or should it be done during the secondary repair? A lot of primary repair surgeons don't know how to put buckles. If you don't know how to do it, I'd say don't. But again, for secondary repair, it depends if the inferior retina is involved or high risk of PVR, then I think a prophylactic scleral buckle or a scleral buckle at the time of the surgery makes a lot of sense. It's technically challenging, but it's doable, and I'll show you an example of that. What does a scleral buckle do? Okay, so this, you see this white linear line here? What you're looking at is, that's the rupture site. This patient had a secondary repair, internal repair, had the retina repaired, you can see there's some laser there, and had a scleral buckle placed where the rupture site was. Remember, after the rupture is closed, we're not putting a buckle on with the eye open, and you can see how it supports the vitreous base. It's not uncommon if you have anterior involvement of the retina and you put a scleral buckle on, that the patient will develop PVR or some proliferation. And what happens is the anterior retina detaches, but the posterior retina is spared. So the buckle prevents the macula from detaching because it's keeping the retinal detachment anteriorly. They always end up with some type of proliferation where the scleral wound is. You have to know the ocular trauma score. The ocular trauma score is based on an initial visual acuity, and the type of injury will lower that probability of good visual acuity. So when we look at the ocular trauma score, it can determine the probability of good vision after surgery. So if you look here, a patient that has, and you could see light perception to hand motion vision in a raw score of 0 to 44, you can see their prognosis is a lot better. I'm going to show you some examples. So this is an example of an intraocular foreign body. Visual acuity was 20/30, and there was no endophthalmitis. It wasn't perforating. There was no retinal detachment. There was no afferent pupillary defect. So the raw score here was actually 100, and then there was nothing that you deducted from that raw score. So if you go back to our table, this patient has a 92% chance of having 20/40 or greater vision. So patients started with 20/30. They have a 92% chance of having that vision or 20/40 or better. But why is it not 100%? Do you tell patients that have great vision with intraocular foreign body that everything's going to be fine, everything's going to be perfect? There's an 8% chance something can happen, right? That patient could develop an infection after the surgery. That patient could develop a retinal detachment. So that's the probability. It's only 92%. And make sure that you tell patients with open globe injuries that even though their probability of getting good vision may be better than because of the mechanism of the injury, it's not going to be 100%. And look at the example here. This is an example of a rupture. So intraocular foreign body, now we have a rupture. And you can see here with hand motion vision. So their raw score without an afferent pupillary defect is 47, and with an afferent pupillary defect, it's 37. And if you look at their probability, with the APD, their chances of getting 20/40 or better vision is only about 1%. Without the APD, their chances of getting good vision is about 15%. But look at the patient with the APD. Their chance of NLP is about 73%. So these are very devastating injuries. But what's happened in retina surgery over the past 20 years is that our ability to address these cases, we now have a fighting chance. Just so that you remember, even though sympathetic ophthalmia is not that common these days, it does exist, and be aware of it. The interval, it's related to the interval between the ocular injury and the onset. It can range from 5 days to 60 years. So 90% usually occur within the first year. In terms of what it looks like, there's leakage in the choroid. And they end up with serious detachments, inflammation. Sometimes the first sign will be loss of accommodation and photophobia. So be aware of that in a patient that occurs in their good eye. This is an example of a patient that had a ruptured globe. He's a 42-year-old male, had a motor vehicle accident. And you could see on the top image, that's how the patient presented. You can see the wound being sutured in place. There was a rupture site from 11 o'clock to 3 o'clock. His visual acuity was bare LP. And the B scan, you can see there's a total retinal detachment, and you can see there's a vitreous hemorrhage. And this is him post-op. Now, this is using very complex procedures, and I will show you a case. This patient had a pars plana vitrectomy, sclerobuccal lensectomy, and they had no iris. So at that point in time, we did something called iris retention sutures, which has been published, where we take proline sutures, put it through the area of the limbus, and it acts as a pupil and actually holds the oil back. And you can see this patient, 4 months, had about 2100 vision with a pressure of 6 to 10. Here's an example of a perforating injury. So you can see it enter by the limbus, and then look at the picture with the retina. You can see where it exited. And you can see that we did a pupillar plasty, very similar to the case that we had, where we tried to get the pupil as centered as possible. Here's a case of an intraocular foreign body, but this case was complicated by endophthalmitis. And I want to show you that picture on the top right, where you just see red and white. Right? So during the surgery, we were able to clear the vitreous, and that's what the retina looked like. And I looked at that and I said, I'm not peeling anymore. I'm not going to touch that, because I felt that the retina was very necrotic and I didn't want to cause any damage. Left it. You can see here, look below. That's 2 weeks post-op. You can see that retinal whitening has actually improved, and you can see the scleral buckle with the endolaser on the buckle. And this patient, this is 1.5 years later, had hand motion vision. You can see that needed a penetrating keratoplasty, and you can see, again, silicone oil retention sutures in the front with the UBM showing that the oil is not touching the cornea. So what you have to know is ocular trauma is the leading cause of monocular blindness. We did discuss the terminology when it comes to open versus closed, the type of open globe injury, the zone, and this is important in terms of communicating. What I want to do now is I want to show you a case from beginning to end. And I think I've showed this before to many, many people. And I haven't seen or met any other professors or teachers that have videos that go from the beginning of the injury all the way to the follow-up. And what I mean by that is from a devastating injury, primary repair, and then secondary repair. This patient happened to be, I think he was 42-year-old man. And unfortunately, he fell and slipped and landed on his eye. His visual acuity was light perception with an APD. And I just want to show you this slide right here. Okay? So imagine he comes in and you're looking at this. Do you see an open globe injury here? Yes or no? Is it possible to have an open globe injury and the conjunctiva is intact? All right, remember that, because I trick people. I show them this, and they say, no, this is not an open globe injury. There's no full thickness opening here. The conj is intact. Well, nope, it doesn't have to do with the conj. It has to do, remember, cornea and sclera. And this is showing you a CAT scan that was done, and you can see a full thickness defect in the sclera. And you can see this is involving actually the lateral portion of the eye wall. And again, looking here, you can see this is involving the superior portion of the eye wall. So this is a ruptured globe, full thickness. It appears to me that it's probably under the muscle insertions, and it's involving the superior temporal area that's extending temporally. So this is showing you day one. Wait a second. Excuse me 1 second. The funny thing is, I came up here before and all the videos were working. Now I come up and the videos are not working. Let me see. Is it possible for the next speaker to go and, is it? Yeah, but I think it's going to be, every single time it's going to be, I think it's going to be delayed. Do you want to just, all right. You want me to keep going? All right, we'll keep. So take a look here, okay? Remember, the eye's very, very soft, and you can see we're really, really, not putting any pressure on the eye to open up the conj. What we know here is that the pressure's low, there's an open globe injury, and we know where it is. Here you can see we have an assistant that's helping here, and you can see the assistant is holding the conj while we're going down and doing a relatively, I would say, sharp dissection. This is not a case where you go in and you do blunt dissection blindly. You want to see exactly what you're doing because you want to really identify, the purpose is to identify where that rupture site is. That's going to be the key. And you want to be able to see the edge of the sclera. In this case, guess what? The rupture is behind the muscle. We are actually identifying the muscle insertion because we know we have to remove the muscle in order to get to the sclera. And you could see here, this is under direct visualization. Now, most of you, when you do your muscles and you isolate your muscles, you take your muscle hook and you just go in there and just pull. In a case like this, when you isolate the muscle, you want to make sure that you're seeing the insertion beforehand. And you could see here, this is our technique, and we're going to suture to the muscle where the insertion is, so that when we cut it off, we can put it back to where it was. Now, why is this important? Because it's very hard to close some of these wounds posteriorly without having good visibility. And here you could see here, we're actually now cutting the muscle. The sutures are there because we want to identify this site. Now, we know from the CAT scan that there was a rupture site in that location. So we know the area that we're going to have to identify and close. And you can see here, you can see the uvea starting to prolapse a little. We're being very, very careful. And what we want to do is we want to get sclera to sclera. Typically, because of this wound, how large it was, there's two ways to close wounds. You can do a zipper approach, is you can find one end and then just zipper it to the end, or you can do a divide and conquer. Put one in the middle, put another one that shortens it and makes it in the middle, and just slowly put together what you can see. As we're doing this, again, you really want to have good visibility and you want to get the sclera to the sclera. And you can see that here. If there's uvea prolapsing, And remember, this is the primary repair. This is not necrotic tissue. You should put it back in. During the secondary repair, the retina surgeon can take care of that. One of the things when you're putting these together is you really wanted to making sure this is watertight. So if you look here, we're measuring the wound here. This is, right now we're at about 18, I think 18, up to 18 millimeter wound. As we progress, if you notice, there's a lot of, there's sometimes more than 2 hands during the surgery. It's very hard to do this case with one surgeon without an assistant. And you can see here now we're actually also removing the superior because we have to get to the wound that's under the superior rectus. And again, this technique you guys know from strabismus surgery in terms of placing the muscle back. And you can see here we're putting the muscle back to its insertion after we've closed the sclera. This is something that most surgeons are aware of. And you can see here, we have the suture on each end of the muscle, and then we bring it up to the muscle insertion. The important thing here is that trying to put the anatomy back to the best way possible, and you want to get a watertight seal. This is, now that we've closed the wound, we're actually making a paracentesis and adding a little bit of viscoelastic to bring the pressure up. And that is a primary closure. What do you think about the lens? This is what the patient looked like day 1 after the primary closure. Right? The lens looks pretty clear, right? There's some blood behind the lens. The pupil you can see is midriatic, okay? We're talking a little bit about his prognosis. We know his prognosis is not good. We know that his visual acuity outcome is not going to be great. So this is when it gets into the hands of the retina surgeon. And because we can't see in the back of the eye, of course, we're always doing a B scan. So we do the B scan, we can see some vitreous hemorrhage. It looks like there may be a low-lying retinal detachment. And then here, you could see here, this is temporally, this is a T3 scan, a transverse scan at 3 o'clock, and we've been reviewing that. And you can see that there's incarceration of vitreous in that area there. That's where the wound was closed. The most important thing, if you're going to do the secondary repair, you need information from the primary closure. You got to get that information. If you're lucky to be the person that did the primary closure, that's great, and you have that information. But very commonly, you're going to get information from someone else that did the primary closure. You got to be prepared and write this down. So this is showing you an example of what I do. Okay, Wendy was a resident at the time. I called her up. I said, Wendy, what happened during the surgery? And the one thing I want to know is I want to know where it is, where the rupture site is, okay, in terms of zones, right? So she said, well, we had a rupture that was 10 millimeters posterior to the limbus. Good. You know it's zone 3. You know where it is. How big is it? She says it was 15 millimeters. And I want to know where it extended. So she said it extended under the lateral rectus and also the superior rectus. Then the next question is, did you remove the muscles? They say yes. So this is all the information you need, because imagine you go into this case and you don't know what the landmarks are. You don't know exactly what muscles were removed. So we talked a little bit about delayed secondary repair versus early repair. We elected to do the delayed, and this is typically what I do. I go 10 days after, and the reason for that is it gives the a better chance for landmarks. We did put a scleral buckle on this eye, so I'm just going to show you some images of that. when we went back in for the sclerobuccal, we did not isolate the muscles that were removed and put back on. We isolated the muscles that were normal, and we isolated them first. The other ones were isolated under direct. And you can see here we put a 42 band. That's one of the instruments with a Watzke sleeve. And this is, and our purpose here is we really wanted to support that area of the rupture site because we know the patient's going to end up with some proliferation. You can see here, this is the Watzke sleeve that we're putting on. Once that's on, then we're getting ready for the vitrectomy. Look at this. That's a nice sized pupil. I think we have we're not worried about visibility here, right? Because the cornea has cleared and the pupil's large. If the pupil's small, guess what? You're gonna have to make that pupil bigger. You want good visibility. If the cornea is opacified or has a scar through the center, beware, you might need a temporary keratoprosthesis. So what do you think we're gonna do here? What's the first step? First step, do we take the lens or not? Do we put a lens implant in? I always trick people with this, right? All the residents, especially the third-year residents, saying, that lens is clear, leave it alone. You don't have to do anything. But I'm gonna tell you to remember that we have to do the internal repair and we have to get to that rupture site. You can't do an internal repair of the ruptured site with a lens in the way. You're gonna cause a cataract. Then the question comes, well, why don't I just take out the cataract and put a lens implant? That sounds reasonable. With this rupture site being 15 millimeters, the chance of PVR or proliferation is very high. You're gonna potentially end up with proliferation by the ciliary body. So typically, if you want, I usually either remove the whole lens or in some cases, I will keep the anterior capsule intact and do a pars plano lensectomy, leaving the anterior capsule intact if I can get through the surgery. So this is showing you an example of a pars plano lensectomy using the vitreous cutter. And remember, this is a young patient, 42 years old. The lens is relatively soft. You can get away with the vitreous cutter. And remember, this is using a 20 gauge cutter at the time. If you look here, you can see there's some hemorrhage there. We're removing a little bit of the cortical material, and we're actually going to end up leaving the anterior capsule. We're removing a little bit of that cortical material that's stuck on the anterior capsule. Now this is the fun part. This is what all the fellows want. They want to get in. What I recommend is stay in the middle, make sure you can see your instruments, and then remove the vitreous. There's something here that I want you to remember. Look how dense that vitreous hemorrhage is. How many days ago did this patient suffer the injury? 10 days ago? Have you ever seen a hemorrhage look like this 10 days after a vitreous hemorrhage in a diabetic? Open globe injuries are different. Open globe injuries, their vitreous turns white very fast. Trauma cases, that's what it looks like. This is not a diabetic vitreous hemorrhage in 10 days is gonna be red hemorrhage. Open globe injuries, vitreous hemorrhage, it's gonna look white and it's gonna be extremely opacified. Here we know the retina is detached, so we just wanna stay in the center and sort of remove the center, and now we're going to the peripheral vitreous. Remember, this vitreous is very dense, so you can't see the retina underneath. What you do is you start in the areas that don't have the rupture site. We know the rupture site is superior and temporally, so we're going to make and try to identify landmarks in the area that there is no ruptured globe. So we're going to go on the opposite side. We want to shave the vitreous base as close to the aura and as close to the vitreous base as possible until we see a landmark of the retina. Now remember, because we've removed the lens, we can actually get good visibility. And you can see here, we've gotten great visibility. Now we're putting perfluorocarbon in. What perfluorocarbon does is it stabilizes the posterior retina so that when you do your vitrectomy, the retina doesn't fly into your vitreous cutter. And you can see here, it's also displacing some of the vitreous hemorrhage. Perfluorocarbon is very, very, very useful in these cases. So we've stabilized the retina, and now we're going, again, additional peripheral vitrectomy, looking for our landmarks. And you can see how dense the vitreous hemorrhage is, and you see how someone is depressing. Someone's depressing, and what the depression does is perfluorocarbon stabilizes the posterior retina. The depression stabilizes the anterior retina. So you do both of those to prevent the retina from going into the port. Here you can see now a little bit of depression, and we're going really anterior here. We really want to remove all the vitreous hemorrhage as possible and as anterior as possible. This is going to end up being a scaffold for proliferation. And you can see here, just trying to get to that dense hemorrhage and just remove it as best you can. It's a very time-consuming surgery that requires a lot of patience. And you can see here, we're sort of identifying where the site is, where the open globe. Now we're on the internal portion of where the rupture site was. And you really want to make sure that there's no vitreous there, and you want to clean this up as best as possible. And you can see here, again, scleral depression, perfluorocarbon's in the eye, and you're trying to get to that wound as best you can. And this is a technique, because the pupil's big, the capsule's intact, this is getting right to that area where the rupture is. And remember, I showed you the scleral buckle with the rupture. When you see white is when you've gotten the hemorrhage out of the internal portion of the wound. And you can see here, we're depressing, we're using a microscope light here, and we're getting right down to the area where the hemorrhage is. And it takes time to do this, and we're just going really slow. When you see white, okay, that's where the retina's been damaged, and now you're looking down at the sclera. Once you have that and all the vitreous removed, you know you're pretty much completed your vitrectomy. You're not completed with the surgery because there's still other things to go on. So if you look here, you can see here, now we're tightening our scleral buckle. You can see we didn't tighten it when we started the case, right? I showed you a little bit of it. Now we're just tightening it, and now we want to support that rupture site, and we want to support the vitreous base. Again, when we put the scleral buckle on, remember, it's sort of at the equator, and now we're doing laser treatment. We're doing laser treatment on the buckle. We're going to do it at the rupture site, but we'll also add some peripherally because of the high risk of PVR, especially inferiorly, and we want to make sure if that anterior retina proliferates, it doesn't take off the macula. When we're doing this, you could see here, at some point in time, we're going to want to get that pupil contracted, because we're thinking we're going to be putting silicone oil in. We're going to want to get the pupil smaller. Okay? If this patient was aphakic, what I mean by aphakic, what I mean by that is if the patient had no lens capsule intact, then you have to do a peripheral iridotomy. Sometimes in some of these trauma cases, the pupil doesn't respond, so we have to use... Oh, okay, all right. Let me just go right to the end. This is... Here, we're taking out the perfluorocarbon, and what we notice is this peripheral hemorrhage, and you can see the anterior fluid's coming posteriorly. When that happens, we're going to do a posterior retinotomy. And you can see here, this is a soft tip cannula. You can see it's going under the retina. And you can see we're draining the subretinal fluid and draining the blood that's under the retina. I'm going to go right to the end here. I'm just going to show you the post-op. I think you'll, here's putting the conch together. You got to make sure that's, okay. This is in post-op. This is the fundus photo post-op. You can see the retina's attached. Look to the right. You see that white line there? That's you looking at the internal portion of the ruptured globe on the buccal. This is what he looked like post-op. Remember, we put oil in the eye. The peripheral capsule actually opacified. What was interesting that shocked me is that there was still a little opening in the center that was clear, and his visual acuity was 20/30 with a plus 8.75 lens. The only thing is, his eyes were crooked. He did have strabismus. 3.5 months later, we removed the oil. We opened up the posterior capsule. He ended up a year later, strabismus surgery. They were able to do strabismus surgery with an adjustable suture. He had a small ET at distance, not big. But again, he needed a head tilt, no intraocular. We couldn't put an intraocular lens in because he couldn't get the diplopia totally right. This is what he looked like. This is a couple of years later. And what I want to show you is, you see that white spot on the top, that pigmented white spot? What do you think that is? You saw the surgery, right? Everyone watched the surgery? Remember I took that thing, that extrusion cannula, and I had to get that blood out? Well, those are called battle scars. That's what retina surgeons call it. And you could see here, you see that linear line of RPE? You could see exactly where my soft tip went. Has no bearing on the vision, but when you see cases, and you have cases, you sort of get an idea of what it looks like. Just so in conclusion, again, appropriate terminology is important. Final outcome is really based on prompt triage and appropriate treatment. And I want to thank you for all your patience on this case. Thank you.
Thank you, Dr. Ronald, for your informative talk. Now, our next speaker is Dr. Sanjay Kedar. He is cornea, uvea, and ocular immunology specialist. He is a professor of ophthalmology at the University of California. He is also the director of ocular immunology service at the Gavin Herbert Eye Institute. With expertise in the corneal transplant, cataract, and pharmacological implant surgery, he has contributed to over 50 peer-reviewed articles and various textbook chapters, showcasing his active involvement in research on treatment efficacy. Previously, he served on the faculty of renowned institutions like the Wilmer Eye Institute, Johns Hopkins, and the New York Eye and Ear Infirmary of Mount Sinai. The topic of presentation is cultural endothelial cells transplantation. Please welcome Dr. Sanjay on the stage.
Okay, well, thank you again for that warm welcome. It's been my absolute pleasure. I'll just reiterate, and I'll speak for the team, that we've really loved our visit here to Nepal. Many of us have been here multiple times. This certainly has been one of our best visits yet, and that's really in thanks to the whole team at REMEH and Scott Hamilton and Dr. Gentili's good leadership. So I'd like to talk today about cultured corneal endothelial cell transplants, and are we ready for them? These are my financial disclosures, none of which are relevant to the talk today. So there are approximately 185,000 cornea transplants that are done each year around the world, 116 countries or so. And yet, despite the fact that all of those transplants are being done, close to 55% of people that need cornea transplants don't have any access to tissue. The number one reason, or one of the top reasons for cornea transplantation is Fuchs dystrophy, followed by keratoconus and infectious keratitis. So as you can see here in the photo on the upper left-hand corner, you can see a patient with bullous keratopathy. The specular microscopy on the right shows corneal endothelial gutata in a patient with Fuchs dystrophy. And our traditional transplantation techniques started with full thickness cornea transplantation, as you can see here on the lower left, but then progressed to the use of lamellar keratoplasty. So what you're seeing here is a patient of mine. We did a DSEC, and we have a live intraoperative OCT connected to the microscope, so we can actually see that there still is some fluid in the interface, despite the fact that we've placed a gas bubble in the eye. We're massaging that to kind of get the fluid out of the interface to allow for good attachment of the transplant. As we've gone to thinner and thinner tissue, so we've gone from DSEC to DMEC, the idea is that we can improve the visual acuity outcomes by reducing the posterior curvature of the cornea. And we can also decrease rejection rates because there's less tissue, there's less antigenic tissue. But one of the problems with that is that, as any cornea surgeon that has gone through DSEC and then has now gone towards DMEC will tell you, it's a difficult transition, and it becomes very technically difficult. So that leads to lower adoption of a surgery that can be better for patients. So what can we do to improve this? Well, one of the things we can do is through cultured corneal endothelial cells. And what that means is that we can actually take donor cells, amplify and grow those cells in culture, and then re-inject them into patients. So the process here is that we harvest these corneal endothelial cells, we analyze them for their suitability for reproduction, and we store them in dual media. So we put them in both a maintenance media as well as a growth media. What we found is that if we only put them in one media, we say maintenance media, or we only put them in growth media, the cells actually don't adhere very well. So the best outcomes are coming from initially putting the cells in there to maintain them, and then amplifying them through growth media. Now, this is where it gets interesting, which is that the surgery for this is actually quite simple. What we would do is to remove the host endothelial cells in an 8 millimeter circular area, and we then inject the cells. We also include a ROCK inhibitor, a Rho kinase inhibitor, and the idea behind doing that is that these cells, if you just insert them into the eye, they have an actin cytoskeleton, and the cells will contract, decreasing their surface area, and they also won't adhere well to the host tissue. So by injecting the ROCK inhibitor, it actually prevents those cells from contracting, and it allows them to an increased adhesion. After this procedure is done, the patient then lies face down for 3 hours, after which they'll come back. Now, what types of cells are useful in this sort of tissue? What they found is that there are certain donors that will provide better tissue than others. One of these is that younger tissue is better than older tissue, and part of that is that about almost half the patients in the younger category, which is below 50, I find that, being a 50-year-old man, I find that offensive that that's considered old, but that's okay. But this is in young patients, about fully half of them may have what we think in the peripheral cornea may actually be like endothelial stem cells. So these cells actually will reproduce quite readily. We want to take the tissue from the peripheral cornea, as I just described. Cells that are tissue that has a greater cell density is more likely to adhere and to reproduce well. We also want to know about the cause of death. So we know that patients that have been on ventilators before we take the tissue, those tissues don't do as well over the long run. So I'll skip some of the other categories here, just to talk to you about the advantages and the concerns. So certainly one of the advantages is postoperative recovery. In patients that have a DMEC or a DSEC tissue, they have to lie face up to allow the gas bubble to adhere, to allow the endothelium to adhere using the gas bubble. But these post-operative recovery for these patients is much easier. After they've lied 3 hours face down, they can do most things normally. It's a very small incision that we use, about 1.6 millimeters. This has a very low detachment rate as opposed to DSEC and DMEC tissue. DMEC tissue can have a detachment rate up to about 5 to 7% in some cases. We can also transplant a much larger number of cells than we would otherwise be able to do with a one-to-one autologous or allogeneic transplant. So we can transplant almost 1 times 10 to the 6th power of cells. And the last advantage, I think, is going to be really, will really change the field of cornea, which is that one donor can provide enough tissue for 300 patients. Right now in the world, we have one donor for one recipient, and that fully leaves about 70 recipients, for every donor that don't have tissue. The concerns, of course, are glaucoma. Could these cells go into the trabecular meshwork, block the trabecular meshwork, leading to elevation of intraocular pressure? Could these cells migrate to extraocular tissues and cause other problems that we're not aware of? Are the cells going to adhere well? And could the cells have uneven distribution? In other words, if all of these new cells lie on the peripheral cornea and you still have central corneal edema, we haven't resolved the patient's visual acuity issues. So the initial study that was done by Dr. Kinoshita in Japan, they looked, their initial trial was really just to see whether they would have intraocular pressure elevation, because they were really concerned about this trabecular meshwork blockage. And in 10 out of 11 patients, they found no intraocular pressure elevation. They also found no abnormal collection of the cultured endothelial cells within the eye. They did some animal studies where they fluorescein labeled the cells, and they were able to show that the cells didn't migrate anywhere else within these animals. Now, this was done almost 5 years ago, and they have long-term follow-up of those patients. And over 5 years, what they found is that, again, 10 of those 11 patients had success, and they defined success as greater than 500 cells per millimeter squared on endothelial cell density. And the reason they use that is that usually below 500 cells per millimeter squared, that's when the cornea starts to get edematous. If it's above that, a lot of times patients can still maintain good clarity of their cornea. And in fact, the average cell count at 5 years was 1,200 cells per millimeter squared, which is comparable to both DSEC and DMEC. Only one of those patients developed glaucoma, and one patient had failure, which was thought to be due to pseudoexfoliative material, causing a poor microenvironment for those cells. Vision improved in almost all of these patients from an average of 6/38 to 6/15. So the company that's leading the charge for development of this cultured endothelial cells is Orion Biotech. Dr. Ed Holland, who's a cornea specialist and a good friend of our institute back in the States, is the medical director and is leading a lot of these trials. And so where are we in terms of these trials? Well, the cultured endothelial cells have actually achieved regulatory approval in Japan, but we're still looking at doing testing in the US and the European Union. And we will be one of those, my institution will be one of those trial sites coming shortly. One other question is whether we can, is it better to take these cells and put them on some sort of carrier so that we can actually use that carrier similar to the way that we would use a DSEC or a DMEC? Well, if we would looked at various materials to transport or to put these cells on, we've used denuded Decimase membranes, meaning we've taken Decimase membrane from patient, removed all the cells, put the new cultured endothelial cells on, and then placed them in the eye. We've also used anterior lens capsule and another synthetic material, LK20. All of these have done okay. Again, they're all preclinical studies in patients. But you might be asking, well, this is just going back to what we've been doing before, so why would we want to put this on a carrier as opposed to just injecting the cells? Well, one is that we might get increased adherence, and the second is that it's more easily reversible. If there's a problem with the cells, we can just take the whole carrier out and remove all those cells, versus if we had implanted just the cells in the tissue, and then we'd have to go back in and try to scrape all of those off. So again, as we discussed before, endothelial cell transplantation versus the cell injection, the advantages with the endothelial cell transplantation are numerous, but I think probably they're fairly even. With the disadvantage, of course, with the cell carrier, that's a more invasive approach. You'd have to use a larger incision, usually anywhere from 2.8 to 3.2. There's also an increased risk for inflammatory reactions involving the carrier. And the patient may also develop interface haze that can cause problems for the vision. So what are the potential barriers to implementation here? Well, one is cost. So there's a high cost to actually culturing these cells. The other one is regulatory quality control, which maybe not all countries will have the ability to do. Development of suitable carriers for a sheet transplantation, so bioengineering solutions, as we described before. And reducing potential contamination. So when we grow these cells, they actually need certain components of extracellular matrix to grow in the lab. And we have to get those extracellular matrices, proteins such as collagen, from animal products. And so if there's xenocontamination, that may cause a problem for these cells and for the patient. Likewise, there's something called endothelial mesenchymal transition. So these cells, if they're left long enough, they will transform into more tissue that was more likely to scar and less likely to help with the endothelial pump function. So we need to maintain certain control over the growth cycles of these cells so that they maintain their differentiation as endothelial cells. So in summary, I think that cultured endothelial cells are poised to revolutionize the way that we do cornea transplantation. And not only because we'll be able to service a greater number of patients in need, but also because if we go with the injectable cell preparation, now this becomes a much easier procedure. And in fact, a procedure that probably most anterior segment ophthalmologists will feel comfortable with. Even normal general surgeons or cataract surgeons will feel comfortable going in to the eye through this 1.6 millimeter incision, kind of rubbing the endothelium off with a silicone cannula, and then doing an injection and having the patient lie face down. So not only are we expanding our ability to service more patients through more tissue, but we'll also have perhaps more physicians that can actually do the procedure. But that being said, culture technique, cost, and regulatory hurdles will need to be overcome before we have widespread implementation for many countries. I want to thank you for your attention, and I'll turn the podium over to Dr. Lisha.
Thank you, Dr. Sanjay, for sharing your expertise through a wonderful presentation. I'm pleased to introduce next speaker, Dr. Christopher Tang. He is a glaucoma specialist and an associate professor at Yale University School of Medicine, is recognized for his expertise in ophthalmology as a former director of the Glaucoma Service and Glaucoma Fellowship. He has received accolades such as American Glaucoma Society Clinician Scientist Research Award and the John Harmon MD Memorial Award for Excellence in Teaching from the New York Eye and Eye Infirmary. Today, he will be presenting on glaucoma procedures in resource-limited locales. Let's welcome Dr. Christopher.
Dhanyavad. That was an awesome talk, Dr. Kedar. And when you said more glaucoma, I was like, no, we were all said, stop the research. Thank you so much. It's an honor to be here. I have no financial disclosures. Namaste. It's been really great being in Dalkabar and Banipa. It's a real honor. And so congratulations to Dr. Shresha, Dr. Malia, Dr. Lisha, and the entire team. And I was so inspired by my trip here that I made this Instagram reel and so many memories. And we think about the Himalayas as the #1 thing in Nepal, but I made it #2 after the heartwarming hospitality of all the Nepali people. So thank you so much. I'm going to talk today about glaucoma in resource-limited locales, and we'll go over a little bit about glaucoma overview, surgical management, review of some select surgeries, and the rankings that I came up with for glaucoma. We all know what glaucoma is. It's a progressive optic neuropathy characterized by damage to the optic nerve with typical visual field defects, and it's most commonly caused by elevated intraocular pressure. And it's the leading cause of irreversible blindness in the world, and the second leading cause of blindness. Over 100 million people affected around the world. In Nepal, though, it's the third leading cause of blindness after cataract and corneal conditions. And various studies have been done in Bhaktapur and Jiran, and the overall prevalence of glaucoma was anywhere from 1.9 to 2.3%. So Nepal, with a population of 30 million, has approximately 600,000 patients with glaucoma, with only about 30 glaucoma specialists in this country. And this is the characteristic visual field progression that we see. It goes from a full normal visual field to severe damage from glaucomatous optic neuropathy. The mainstay of treatment is drops and then laser and then surgery. That's been the typical algorithm over the years. But sometimes drops has difficulty. There's the expense, there's the difficulty with the administration and the adherence of the patients. And SLT is a great option, but there's also the cost of that machine, which costs a lot of money. And also a little bit of an education learning curve to do the SLT lasers. So the mainstays of glaucoma treatment have been typically trabeculectomy and glaucoma drainage implants, otherwise known as tubes. Nowadays, there's been a big push to fill the laser, surgical, and tube and trab gap. So there's been a push for minimally invasive or micro-invasive glaucoma surgeries. This is the range of glaucoma surgeries that we have these days, anywhere from tubes to trabeculectomy to MIGS, and I put a little subset of cyclophotocoagulation there on the bottom. That also takes another machine that costs a lot of money. The microinvasive glaucoma surgeries have been a lot. There's been a lot of innovation and excitement in glaucoma, and this is the list that I came up with, and there's more to come and more that's been developed. But trabectome, Cahook, GAT, Omni, iStents, Hydrus, iAxis, these are typically devices that come in boxes that cost a lot of money that sit on shelves until you need to use it. There's also the Zen Gel Stent, which also is a device that is a modified trabeculectomy, and endocyclophotocoagulation, which also takes a box that you connect the probe to. So what glaucoma surgeries can we do in resource-limited locales? Well, there's a trabeculectomy, there's the glaucoma tube implants, and thanks to Oralab in Aravind, they've came out with the ADI implant, which is similar to the Barvelt glaucoma implant that was invented at Sanjay's institution in Irvine. There's also various types of blades that we can use to make goniotomies, such as the Cahook dual blade, and there's a newer procedure called the bent ab interno goniectomy, which just bends a 25 gauge needle. And there's another procedure called the GATT procedure, which is using a Prolene suture to thread internally in the trabecular meshwork, Schlemm's canal, where you can create a trabeculotomy 360 degrees. So I came up with a few criteria for resource-limited settings, such as IOP control, efficacy. What about the cost, the economics, the additional equipment needed? How about complications, the burden on the patient, and the degree of difficulty and the burden on the surgeon performing the surgery? So trabeculectomy is the mainstay. There's limbus-based and fornis-based trabs, and they work beautifully. It's still considered the gold standard, and it's proven, scientific studies throughout the world, multiple studies. The advantages, this is the lowest pressure that you can possibly get in the eye. There's no other single surgery that can take the pressure to 4, to take the pressure to 6 or 8. But we all know it's very, very difficult to get there. You don't really need any additional surgical equipment. Mitomycin is basically available throughout the world. And by the way, you can do trabeculectomy without mitomycin as well. It just has maybe a higher risk of scarring over. There is a learning curve, but typically doctors that I've met all throughout the world are familiar with this, glaucoma doctors at least. But we all know trabeculectomy can cause a lot of comorbidities, such as blood leaks, shallow chambers, poor vision, choroidals, and endophthalmitis in the long term has a 1% risk per year over time. So here are the rankings that I gave trabeculectomy and IOP control. It can't be beat. It gets from a scale of 1 to 10, it gets a 10. Cost, there's no surgical equipment needed. It gets a 10. Complications, burden, we're going to cut that a little bit. We'll give it a 5. And the degree of difficulty is also difficult and challenging. We got to do some fine dissections, etc. And it's also a burden on the doctor to the heart when you see complications from trabeculectomy. Everyone here has seen those, so we'll give it a 5 for that. So the score is 30 for trabeculectomy. Tube implants, we got Barvelts and we have Ahmeds are the two predominant ones in my country. We don't have the Orlab Adi implant, but that is similar to the Barvelt. And these were two of the surgeries that Dr. Diksha did in this hospital. A beautiful sulcus tube implant in the neovascular glaucoma patient, and then we also did the inferior temporal tube in a patient with silicone oil. With silicone oil, since it migrates superiorly, we want to put the tube inferiorly. So tubes are an excellent procedure for primary or secondaries, and it's proven efficacious. They've had tube versus trab studies, and the tube has performed really well. It gets good pressure, typically in the teens, and it works well when other surgeries have failed, but there's also disadvantages, such as the price, the learning curve, and the post-op complications with tube also has, such as shallow chambers and choroidals, and also hypertensive phase and scarring of the tube and exposure of the tube over time. So what do we give the tube here? I gave it a score of 24. IOP control is good, but it's costly. We'll give it a 5 for that. Complications, you also have complications, but not that many if you know how to management, but also is a burden on the doctor because of the learning curve, etc. But tubes performed really well. The primary tube versus trabeculectomy studies showed that tubes were similar in efficacy to trabs, but trabs might be a little bit better. So trabs are a better option for primary surgeries on patients. Okay, now let's go to the MIGS surgeries. Pretty much all of these get knocked off the chart, and I cross those off because they're very expensive. These devices are not cheap. But which are the ones that I showed before that are pretty straightforward with no additional equipment? That's the GAT and the Cahook blade. So we'll talk about those. The Cahook is a blade that also is a box on the shelf, but it's cheaper. That's why I included this. But goniotomy only gives mild IOP lowering, and typically it's done adjunctive with cataract surgery. But there's really, really low potential for any type of severe complications. The most thing you get is a little bit of sustained hyphema, which atropine and prednisone really take care of. Disadvantages only gives a little bit of pressure lowering, let's say 2 to 3 millimeters. There is a mild learning curve, but any glaucoma specialist with good intraoperative gonioscopy skills will be able to overcome this. There's a video of Cahook blade. It's basically a blade that you take. As long as you get good visualization, you can just scratch a trabecular meshwork off one way and then go in the other direction. I have these videos on YouTube and TikTok. Unfortunately, I know what happened at TikTok, so we'll stick to YouTube for these. Okay, so Cahook blade, what do we hear? We got IOP control of 5. It's not so great. It does the job, though, in certain cases. The cost, 5 also, because you have to pay for it. It's on the shelf. Complications, almost 0, so we'll give that a 10. Degree of difficulty, a 7. The doctor, glaucoma doctor with good intraoperative gonioscopy skills, identifying the trabecular meshwork, will be able to perform that. But what do we do instead of the Cahook blade in the developing world is this, the bent ab internal needle goniectomy. You basically take a 25 gauge needle and bend it at the tip and does the same job as the Cahook blade. And there's low potential for severe complications. If you want to do goniotomy and you don't even have a 25 gauge needle, you can just take the straight MVR blade and just cut the angle and open up the trabecular meshwork that way. And I know you have straight MVR blades, and you just extend across the angle, do 90 degrees of goniotomy, and just make sure you're cutting the trabecular meshwork and not the ciliary body. You get a little bit of IOP lowering with this, but there's a little bit of skill involved with intraoperative gonioscopy, etc. So make sure the key here is to take your finger and offset when you bend the needle. It's important to put your finger there, otherwise you're going to get the bend in the wrong place, and you just really need it at the tip. So offset that with your finger. Take a strong instrument. Don't use the needle driver because you don't want to damage it. So you can take the clamp there, and then you just extend across. You don't make it a 90-degree angle. You want to make it a little bit obtuse because you're just literally just scratching the trabecular meshwork. And then you identify the trabecular meshwork structure, go across, and then you're just basically scratching the trabecular meshwork open, just like I showed with the hook blade. Now, if it's an MVR blade, you won't really be able to remove the trabecular meshwork, so you just use the MVR blade to slice open the trabecular meshwork. So what do we give the bang? 5 for IOP control, 10 for cost. It's just a needle. Complications, burden on patient, it's basically just hyphema that's going to go away, and degree of difficulty is the same, it's 7. This is a doable procedure. So we'll give it a 32. How about GAT? So GAT is gonioscopy-assisted transluminal trabeculotomy. It's basically taking a suture and going across in the angle. You make a little cleft goniotomy with the MVR first, and then you extend it into the angle, into the Schlemm's canal, and hopefully you can extend it 360 degrees, and then you pull it, and then you get a 360 degrees of trabeculotomy. Advantages, this gives great IOP lowering because you're opening up the entire angle, and you can do it with or without cataract surgery. It targets 360 degrees, and there's the low potential for severe complications other than hyphema. It's not going to cause choroidals or anything that other surgeries and glaucoma, and it's low cost will cause. So there's some learning curve. You need to buy the Swan-Jacob lens for any gonioscopy angle, right? So that's one cost that's added, but you can reuse that and sterilize that. You need to have a cautery to burn the tip because you have to cause a little bulb on the tip to help facilitate the movements. Otherwise, if you just cut the proline, it's a little bit sharp. And you need to have a micro forceps. You can either use retina forceps or just buy a kit of microsurgical forceps that are reasonably priced from Nepal or India. So this is the video here. We've cut a goniotomy cleft a little bit using the MVR and then using the Swan-Jacob lens and then the micro forceps. You're threading the proline and then hopefully it goes 360 degrees. I was talking to Dr. Indira before. Sometimes it goes 360. If it doesn't, then you pull it when it's at 180. You go one direction to the left side, and then if you're a righty, and then you come around and go to the left side. And then you pull it, and then you get a 360 degrees of angle opening. So this one, I think, is a great one. So IOP control, 9. It's not as good as trabeculectomy, but it's maybe the next best thing after a tube because the tube costs a little bit of money. And this one is just a proline suture, 5-0. 8, and then complications is just hyphema, so that's a 10. Degree of difficulty is also 7, so this one gets a 34. So in my rankings, this is how I ranked it. GAT first, bang second, trabeculectomy 30, fourth, third, and then KDB 27, and tubes 24. And this is taking into account everything. This is taking into account the price, the degree of difficulty, the burden on the patient, and IOP lowering. So what is it about GAT? Well, it's good safety profile, good IOP lowering, decreased medications, rapid recovery, no fancy device needed, spares conjunctiva. You can still do a trab or a tube after if it doesn't work. So this is what I call a stepwise approach. You first do drops. If you don't have laser, then you skip laser. Then you can do this procedure, or you can start with a goniotomy, and if that doesn't work, then you can escalate to this and then escalate to a trab or a tube. So this was a survey paper that came out in 2018, and this was asking glaucoma specialists, if you had glaucoma and can pick any procedure, you already had laser, which one would you pick out of the approved devices in the FDA? Now, GAT was first invented. It came out the paper in 2014. They first started doing it in 2011. Ron Feldman in Dallas, Texas, in the United States. In 2011, the paper came out in 2014, and this paper came out in 2018. So the 4 years difference between when it came out and when this. So they surveyed the American Glaucoma Society, 27% responded, and the number one choice for the glaucoma specialist was GAT. 20% of them picked, and then you see where trabeculectomy, Barvelt, and some of the other procedures fall. So within 4 years, this procedure really took off in the United States. And this is a nice paper. They stratified it based on amount of pressure that you started off with, and then also the age of the respondent. So look at how good GAT performed just in a 4 years time, right? So it performs really well. So there's many great glaucoma surgeries. Some are better, than others, especially in resource limiting places. And yes, I know that this might be an oversimplification, but it depends. I know it depends on the pressure and it depends on the situation, right? And the needs that we need to balance are the needs of the patient, what's available, the cost, morbidity, skill and comfort of doctor, and the outcomes. Dhanyavad.
Thank you, Dr. Christopher, for delivering the wonderful presentation. I would like to take this opportunity to express my heartfelt gratitude to Dr. Christopher. Working with him over the past few days has been great experience. He is an amazing coach and instructor. A sincere thank you to Dr. Christopher for his invaluable guidance and teaching.
Our next speaker is Dr. Omar Ozgur. He is oculoplasty specialist. He is a board-certified ophthalmologist accredited by American Society of Ophthalmic Plastic and Reconstructive Surgery, specializing in medical and surgical management of eyelid, tear drainage system, orbit, and upper mid-face abnormalities. Based in San Diego, California, he is affiliated with Scripps Clinic Medical Groups. His career is marked by his integrations of computer technology with medical care, highlighted by his role as a co-investigator at the Johnson Space Center, where he investigates ocular, orbital, and facial changes in astronauts. Today, he will be presenting on eyelid and trauma repair. Please welcome Dr. Omar on the stage.
Namaste. Thank you so much for having us here. It's such an honor to meet all of you and work together and to share some knowledge and learn from you. It's been such a wonderful experience this week. Thank you. I have no disclosures to report. So thank you for the wonderful introduction. So I do oculoplastic surgery per face. Now, this talk I oftentimes like to give in a discussion setting where we can talk about things, and I'm happy to take questions. If that doesn't work in this setting, please ask me anytime today. I'm happy to discuss any of these things in more detail. You can always contact us too for more questions. But today I wanted to talk a little bit about the eyelid structure and how it's important for ocular health. And when we have a defect of the eyelid, whether it's from trauma or from malignancy, it's important to restore it, not just for the cosmetic reasons, but also for the maintenance of ocular health. So we'll talk about some of the basics of neoplasms, whether they're benign or malignant, because that also relates to the eyelid function and structure. And then we'll break down the eyelid wound repair into kind of the small, medium, and large categories. And by learning some of these principles, you can handle any eyelid issue that comes just by breaking it down to the core concepts. And that also relates to traumatic cases, so we'll go over some examples of that as well. So when we talk about eyelid anatomy and its importance for ocular health, a lot of times we divide the eyelid into the anterior lamella and the posterior lamella. The anterior lamella is more of the skin and orbicularis, but the posterior lamella includes the tarsus and the conjunctiva. And it's really that posterior lamella that's important for maintaining the structure of the eyelid. If the posterior lamella is not there, then we're going to have a lot of issues in functionality. If the anterior lamella is not repaired properly, then we're going to have more issues with cosmesis, as well as functionality. And in the bottom picture, we have more of a front view of the eyelid, where we have the lacrimal gland, which we have to take in mind when we're dealing with issues around that area in the superlateral portion of the orbit. And medially, we have the lacrimal system with the tear duct drainage system. We have the puncta and the canaliculi going into the lacrimal sac and the nasolacrimal duct. So when there's trauma or malignancy in these areas, we have to take into account these areas to see if there's further repair that's necessary. So eyelid neoplasms, we oftentimes break it into benign and malignant lesions. So benign lesions, I'm sure you've all seen enough chalasia and papillomas, acrocordons, hydrocystomas, some more xanthelasma, nevi, seborrheic keratosis, and syringomas. All these lesions, whether they're small or large, we can remove them in sort of the similar techniques, which we'll talk about a little bit later. But first is identifying these suspicious lesions. And of course, the categories of these with pediatrics we have to take into mind, because even a benign lesion might be detrimental for pediatric cases because it can induce amblyopia. So our capillary hemangiomas and neurofibromas, again, we have to deal with more specifically in its relation to how the visual function is. So a little bit more on malignant lesions. So I'm going to show some pictures here. And for our residents and fellows, we have a few different lesions. In the first picture, you can see, it's hard to see, but there's basically just loss of eyelashes and no identifiable mass, no nodularity, just loss of lashes. And in the second one, we have this pearly vascular lesion, also with some loss of lashes. Then we have a big ulcerated lesion. It's hard to identify what's what there. Similarly below that. And then here we have another pearly nodule, and then an ulcerated lesion. And what I wanted to show with this is, even though these all look kind of different, this is all basal cell carcinoma. So basal cell can look like a lot of things. There's the typical pearly vascular lesion, but then there's also these other non-specific ways that it could be very hard to identify. So it's very important when there's an eyelid defect, an eyelid lesion, if it's changing, if it's growing, if it's causing symptoms, have a high level of suspicion. If it needs to be removed, remove it and biopsy it, because sometimes something that doesn't look like a cancer could be a cancer. Especially like with this, just loss of lashes. That was the only thing there. Squamous cell carcinoma, it can arise from the conjunctival side or the skin side. And again, this can look like different things as well. So we have this conjunctival-based squamous cell carcinoma, and then the next picture over, it's more on the skin and ulcerated, similar to the one on the bottom there. And this poor lady, she had an exoneration for a very extensive squamous cell on the left side, and then she developed squamous cell on the right side. It was a very unfortunate case. Keratoacanthoma, this is treated as a squamous cell, and it can also look like different things, but it has this pitted appearance oftentimes. Now, anytime we have a patient with blepharitis that's not improving, or unilateral blepharitis, or chronic chalasia that's not improving, or recurrent chalasia, we have to be suspicious for sebaceous cell carcinoma. Even though it's not as common as our most common basal cell, this does happen. And whenever you see unilateral blepharitis, think it might not be blepharitis and it might need a biopsy. Merkel cell, it's not as common, but it can be very malignant. So again, just like with all the others, high level of suspicion in something that looks so irregular. Melanoma, another lesion that can arise from the conjunctival side or the skin side. In this first picture here, this was a younger woman in her 20s who developed ptosis, and she was referred to ptosis after seeing a few doctors. And when she came to our institute, we flipped the lid and saw the melanoma. It was not identifiable without flipping the lid. So sometimes it's important when you have a patient with ptosis to flip the lid and make sure there's nothing else going on. But you can see on the bottom lid, sometimes this was a patient who had melanoma previously, and then showed up with recurrence. Sometimes you have to look under the lid to make sure there's no recurrence of melanoma. Oh, and the left side, sometimes you can have some mild pigmentation. Sometimes with racial melanosis, it's hard to tell what's normal pigmentation versus irregular pigmentation. So you have to look at the structure of the eyelid, see the architecture, see if there's any change to the architecture, or if there's any history of change, and be suspicious enough to biopsy if necessary. So now eyelid reconstruction. So like I mentioned, we have to fix the function and the cosmesis. And we do that with a variety of flaps and grafts. This image just shows when there's a defect of the anterior lamella, just the skin, there's a variety of flaps that we can use in order to fix a defect. And if you look at the geography of these flaps, it highlights an important feature, and that is whenever we have a defect in the upper lid or the lower lid, we want to minimize the vertical tension. And we can have horizontal tension, but we never want that vertical tension, because that's when patients are left with retraction of the lower lid or the upper lid. But that's, if you look at the geometry, that's what these little flaps are doing. Similarly with the V to Y plasties or Z plasties, it's to minimize the vertical tension. So that's when there's just an anterior lamellar defect. When there's a full thickness eyelid defect, this is when we get into the small, medium, and large categories. Now, what I tell residents and fellows is, what is large, medium, and small? It's kind of arbitrary. Sometimes a small defect can be harder to repair than a large defect. And that is really because laxity is very important. And laxity is not something you can see in a picture. You have to actually examine the patient and see how much looseness there is in the tissue. If there's a large defect with a lot of laxity, it's easy to repair. If it's a small defect with no laxity at all, it could be more difficult to repair. So, as general concepts, with a smaller, more lax defect, we can sometimes do a direct closure. And that's simply with a 2-layer closure where we close the tarsus and the conjunctiva in 1 layer along with the lid margin, and then we close the skin over that. If you look at the first picture there, for the posterior lamellar defect, the tarsal sutures, we want to be sure that they're partial thickness. You don't want the suture end rubbing against the ocular surface, otherwise the patient will be very uncomfortable. Now, once we have that posterior tarsal closure, then we could align the skin very easily. Now, most important is that tarsal closure. If it's offset either vertically or anterior-posterior, patients are going to be very uncomfortable. That's going to lead to exposure and chronic tearing and possible infection. So you have to make sure that tarsal closure is adequate. Otherwise, I tell residents and sutures and fellows to redo the suture. Now, sometimes in this picture, we have a very small defect, it looks like, but there's no laxity. So sometimes we can do a lateral canthal release, a canthotomy and cantholysis that allows the tissue to shift over more, and that allows better closure sometimes. So with a small defect, that's like a small defect +1, that we can allow a little more closure that way. So after the tarsus is closed, then we can close the skin, and that's done. One important thing is, I'm sure everybody knows, but when the lid margin suture is placed, we usually leave the tail long so that we can incorporate that tail into the more inferior wound closure, or for an upper lid defect more superiorly, so that we can keep those suture ends away from the ocular surface. Now for the next category, when it's a little too large of a defect for direct closure, then I go to oftentimes a periosteal flap. If we cut down to the lateral orbital rim and get to the periosteum, there's a lot of tissue there that we can use to restore that posterior lamella. So in this picture here, we're showing where we take a little strip of tissue from the periosteum, we flip it around, and we use that flap as a posterior lamella to repair that defect. So here's an example, and here I cut down to the lateral orbital rim. I drew the rectangle of where I want that flap to be. And if you notice, this will offset a little bit superiorly because as it flips down, it's going to relax a little bit. Another important point is I usually oversize it because any tissue like this is going to condense down once you cut it. And here you can see once the flap is flipped around, it aligns nicely with the more medial portion of that defect. I put some stitches to close that posterior lamella, and once that posterior lamella is done, then we can just close the anterior lamella with a skin flap. If there's not enough skin, you can put a skin graft over there. Now, when the defect is too large for that, then we have the option of a Hughes flap. So this is a lid sharing procedure where we're taking tissue from the upper lid, we're taking the tarsus and the conjunctiva, we're bringing it down to repair that defect, and that's going to maintain that posterior lamella. The vascularity is important for this procedure. We need that conjunctiva to stay attached because that allows the tissue to fill in with its own vascular supply so that later we can divide the lid. Now these lid sharing procedures are tough for the patient because this requires a second stage surgery. So during the period between the first stage and the second stage, the eyelid is going to be partially closed or if not fully closed. And so that becomes a factor that we have to really talk to the patient about because sometimes patients might have very limited vision in the other eye. And if we're telling them that they're not going to see from this eye that's being operated on for a period of 3 weeks to 6 weeks, then that's a factor that they need to really consider. Here's an example. This is an example from that first patient of basal cell I showed. So once the cancer was removed, we had a defect we needed to fill. And I'll show you the Hughes flap. This is where we brought the conjunctiva and tarsus down. We sutured it into position and closed. This was a skin flap from a blepharoplasty type wound that was brought down below and sutured into position. Now on the other side, that's what the wound looks like in that intermediate period between stage 1 and stage 2 repair. It looks kind of granular like that, but with time it heals very well. And then in the next picture down, you can see what it looks like once it's healed. Now, a lot of times a defect is so large that we need combined techniques. So this patient had a melanoma with loss of most of that lower lid and loss of the lateral canthal tissue going up to the upper lid. So for the upper lid, I did periosteal flap. And for the lower lid, I used the remaining upper lid tarsus and conjunctiva to repair that lower lid defect. And as you can see, he healed very well. Now the Cutler-Beard procedure is used to repair a large upper lid defect. Fortunately, there aren't as many large upper lid defects. Usually the large ones are lower lid, and that's because basal cell and a lot of these carcinomas involve the lower lid primarily. But when there's a large upper lid defect, we get limited on what kind of procedure we can do. And so this is an example of a Cutler-Beard procedure where we're bringing tissue from the lower lid to replace the upper lid defect. Now, one difference between a Hughes procedure and a Cutler-Beard procedure is in the lower lid, there's a smaller height of the host tarsus. So we can't use that tarsal tissue to replace the upper lid tarsus. So when we bring that tissue up, it's mostly just the conjunctiva. And a lot of times we use a spacer graft, an allergen material, or ear cartilage to replace that tarsal support. Now, when there's injury to the lacrimal system, then it becomes important to repair that canaliculi system. If you don't, then oftentimes the system will get scarred closed, and it's very difficult to repair a defect that's already scarred. So it's good to do that during the primary repair. And it can be done either with a bicanalicular stent or a monocanalicular stent. Once the stent is placed, then you just place the sutures to repair that lid margin around that stent. This was a 92-year-old female with basal cell carcinoma, and you can see that it involved the medial canthus and the canalicular system. So full thickness skin grafts, this is an important technique, and what you can see here is a basic blepharoplasty. Blepharoplasty, I tell residents and fellows, is so important to learn for this reason. When you're repairing an anterior lamellar defect, this is the best skin tissue to use if you can't do a flap. It's using upper eyelid skin to repair a defect, and what they always say is repair like with like, and eyelid tissue is best repaired with the upper lid skin. If there isn't enough skin to repair a large defect, then sometimes we use posterior auricular skin or preauricular skin. If there's still a bigger defect and there's not enough tissue, then sometimes we go to a supraclavicular area. And that is because we want the thinnest skin possible for repair. Tarsorrhaphy, this is an important technique. Sometimes we want to immobilize the eyelids during the healing period. And so we can do a tarsorrhaphy, whether it's temporary, like in this on the right side, on the left side, or a permanent tarsorrhaphy where you can see the lid edges are fused together. So now some traumatic cases. This was actually a farmer that we saw a few days ago, and he had this trauma, many areas all over his face and his body. But as you can see in this bottom picture here, the lid margin is angled upwards into a peak, and right in that area there was a lot of scarring. We ended up taking him to the operating room. We opened up that scar tissue. We found a lot of granulation tissue, some foreign body material, and we basically, when I have a case like this, I almost treat it like a cancer case, where you cut out the diseased tissue, allow the tissue to relax, see if the tissue will come together. A lot of the tissue was very friable. I think it was probably infected and he was on some antibiotics, but the tissue is still very friable. So we removed some of that tissue, and on the right side you can see we realigned the tissue. So now the margin is nice and smooth. It's very tight and tautic, but that's oftentimes what it looks like after a large reconstruction. What you can't see in this picture is there was no levator function on the left side, but on the right side, once we relaxed that tissue, there was return of some of the levator function. So I think with time he'll do well. This was a little girl who unfortunately had acid injury when she was 3, and she had loss of much of her eyelid tissue to the point where when she closes her eye, she had a good Bell's reflex, but no motion of that upper lid. So I did a large reconstruction where I took posterior skin from both ears, and I used it to reconstruct that upper lid. And I had the opportunity to see her over the next few years, and she had good function of that upper lid. What's important with these cases is you always need to oversize these grafts because there's always a lot of contraction. But thankfully she did well there. This is a little boy with a pencil injury to his eyelid. And you know, when traumatic wounds look scary, if you stick to the core concepts, then anything can be broken down. And for this, for example, we made a relaxing incision medially and laterally so that I can loosen up that pencil and pull it out. Thankfully, avoided most of the important structures, put some stitches, and he was happy the next day. So he did great. So I know that's a lot of information to cover in a short period of time, and again, I'm happy to discuss any of this. You can email me or WhatsApp me if any questions come up. All right. Well, thank you very much.
Thank you, Dr. Omar, for the insightful presentation. Now we have Dr. Sanjay Kedar once again on the stage. Over to you, sir.
Okay, I'm back. I don't know whether they gave me 2 lectures as a punishment or as a reward. So I thought today I'll talk about my thoughts on uveitic glaucoma from a uveitis specialist. It's a long title, but when do I refer to my glaucoma colleagues and what tests do I order? So I just want to briefly tell you where I'm from. I'm from the University of California in Irvine. It's in Southern California, and we're quite close to Disneyland. So you see down there in the map, Southern California, and we're all the way down there. And that'll become more relevant through the talk. So the first thing I want to tell you is that when, as uveitis specialists and glaucoma specialists, we often look at the same problem from different sides, right? So the glaucoma specialist is concentrating on the pressure, the uveitis specialist is concentrating on the inflammation. I'm giving medications that are going to make the more problems for the glaucoma specialist, and the glaucoma specialist potentially is going to do procedures that will make the inflammation worse from my end. But I think it's important that we work together on these patients. Let's see here. So I think that it's important to refer, the best thing to do is to refer early. And so when do I refer to my glaucoma colleagues? Well, whenever there's optic disc cupping, if there's pre-existing glaucoma, or if there's a history of steroid response, I'll refer to the glaucoma specialist, because I know that in these patients with uveitis, we might run into problems over time. And so I'll want the glaucoma specialist to weigh in. I don't want the first time they're seeing the patient to be when they're having a problem. Also, if there's any odd physiology or odd anatomy where it's going to be hard for me to tell if the glaucoma is progressing based on the optic nerve appearance, or if there's such as myopic discs, if they're difficult to interpret RNFL, or the visual field is abnormal, I'll send them to the glaucoma specialist just to get a baseline reading. And last, if the patient has controlled glaucoma or ocular hypertension on multiple medications, I'm going to get the glaucoma specialist involved. And why do I do that? Well, at a certain point, I may run out of therapies that I can give the patient to control the pressure, and I'll want the glaucoma specialist to weigh in at that time. In addition, we're going to refer anybody that has glaucoma or ocular hypertension or is a steroid responder who has an allergy to sulfa or to the other glaucoma meds, we're going to refer early. The main reason being, again, we have limited treatment options based on those allergies. In patients that have chronic uveitis, oftentimes I will also refer to the glaucoma specialist because these patients may need topical steroid therapy or oral steroid therapy long term. If the patient has any contraindications to immunosuppressive therapy, so this is for non-infectious autoimmune uveitis, if they are unable to tolerate immunomodulatory therapy, for instance, perhaps their white blood cell count is already very low, if they're immune compromised in other ways, we'll refer to the glaucoma specialist. And lastly, if I'm going to implant any long-acting steroid materials, such as the fluocinolone implant or Retisert, or if I need to do multiple intravitreal injections, I'll refer again to the glaucoma specialist. So I want to start out by just talking a little bit about the inflammation here. So it's very important in these patients with uveitis, when we're going to undergo surgery, it's important that we remember that prior planning and preparation prevents poor performance. That's only 6 Ps. The 7th P, this is a British Army saying, the 7th P is probably not appropriate for me to use in a lecture setting. So, but what we want to do is to avoid this photo here on the right. So this is a patient that had cataract surgery, was referred to us. The first referring physician had not controlled the inflammation adequately, and we had iris optic capture of the IOL. So control of inflammation is paramount. And why is that? Well, if you have any active uveitis at the time of, let's take for example, cataract surgery, it's associated with a poor visual acuity outcome. And in fact, if they have active uveitis within 3 months of cataract surgery, it's associated with a 6-fold increase. They have a 6 times higher rate of cystoid macular edema after surgery. So make sure to control the inflammation prior. In addition, if the patient has had cystoid macular edema within 1 month of surgery, it increases the risk of having macular edema after surgery, again by 6 times. And if they have any prior history of cystoid macular edema, it increases their risk by 3 times. So this is important in counseling the patient when you do surgery, that if they've had this before, there's a good chance they might have it after, and they should expect that they might need additional treatment, and that visual recovery will be a longer amount of time than a routine cataract surgery. So how does this all bear on glaucoma or glaucoma surgery? Well, we want to try to control inflammation, but on the other hand, time is nerve tissue in patients with glaucoma, right? So if the pressure is high, do we really have time to control the inflammation prior to surgery? Sorry, the last thing I want to say here is, if you need to do glaucoma surgery to prevent further nerve degradation, then you should do it. Don't worry about the inflammation. We'll have to deal with that and control that. But even if you can try to get the patient on some oral steroids, topical steroids for a few days, if you think you can temporize them for a few days before doing surgery, that can also have a positive impact on the results of glaucoma surgery. So even if you can't get the full 3 months, if you can get a few days, that's better than nothing. In addition, we always want to try to establish a diagnosis in these patients, okay? Patients with uveitis, about half of them will have an underlying diagnosis. So this picture on the left here is a 37-year-old gentleman from the Dominican Republic who's being taken care of by some of my colleagues in New York. He had inflammation, unilateral inflammation, and had been placed on acyclovir, which wasn't really controlling things that well. He's on maximal medical therapy, including acetazolamide orally, and pressures were still not well controlled, and they were going to take him to the operating room. I had just joined the faculty there in New York, and they said, well, why don't you take a look at this patient? Well, one thing that I noticed when I looked here at that arrow, it's maybe not as visible on the screen here, is that there's an area of linear keratotic precipitates and focal corneal edema. And that oftentimes can be found in a patient with CMV iritis. So this was a case of cytomegalovirus iritis. So again, patients with unilateral inflammation, if they have ocular hypertension syndrome, so inflammation along with elevated pressures at the time of inflammation, it's a strong predictor for viral uveitis. This patient, we ended up putting on valganciclovir after performing an anterior chamber tap and confirming by PCR that it was cytomegalovirus. After we got him on all the anti-inflammatories, we were actually able to get him off of all of his medications. So here, this is the typical testing that I'll do on the left for a patient with uveitis. And IGRA stands for immune gamma release assay, and that's for tuberculosis. I'm not usually ordering the tests on the right here, and I'm going to skip reiterating all of those just in the interest of time. When we use corticosteroids, and we don't want to keep the patient on oral steroids for a long time, so we'll institute immunomodulatory therapy. But one thing we have to realize, oftentimes I'll get told by my glaucoma colleagues, we'll just put them on methotrexate, and then hopefully we'll get them off steroids, and then the pressure will come down. But the problem is that those medications don't work quickly. Oftentimes they can take months to work, and in our case, even with immunomodulatory therapy, success is considered getting them down to 10 milligrams a day or less of oral prednisone. So some of these patients may still need to be on oral steroids, even though we have them on immunomodulatory therapy. So it's not 100% effective at steroid sparing for any of these drugs. So we do want to use perioperative corticosteroids. So unlike cataract surgery, we might not have the luxury of starting steroids prior to surgery, but we try if we can. And ideally in these patients, you want the steroids on board prior to surgery to get the best results. So I'll show you here, this is what I normally do for my patients who are undergoing surgery. If they have a non-infectious uveitis, we'll start them on prednisone 1 milligram per kilogram per day, beginning 2 days before surgery. On the day of surgery, we'll give them intravenous solumedrol. That's usually 62.5 to 125 milligrams intravenously. For the 2 days after surgery, we're keeping them again on 1 milligram per kilogram per day. We're using a maximum of 60 milligrams per day because beyond that, usually you don't get as much, a greater result in terms of anti-inflammatory capability, but you do increase their risk for adverse complications. And then we taper those steroids by 10 milligrams every 2 days. So it's a total of about 12 to 14 days of oral steroids. And if we do that, we find that we can reduce those postoperative complications in patients by about 80%. It's based on some studies that I had done years ago. We can also use intraoperative treatment, such as Ozurdex or Retisert implant at the time of surgery. We can use difluprednate, which is now I think available in India as well. I'm not sure. I think it's available in Nepal, but I know it's definitely available in India. Difluprednate can work very well. Or we can use the fluocinolone acetonide injection, or which we call YUTIQ, down here on the lower right. And we found that if we use intravitreal injections at the time of surgery, we can get fairly similar results to using the perioperative oral steroids that I described earlier. Now, in patients with glaucoma, that may be difficult because especially if you're putting in a tube, the tube may not open for a month or so, and so you might have to deal with the steroid response by giving them an intravitreal injection. So postoperatively, we want to be aggressive with oral steroids. We want to be generous with our use of steroids. And we want to slowly taper. Don't be in a rush to get them. If there's still inflammation, you don't want to be in a rush to get them off of those steroids. You want to try to keep them on, watch them with, I always tell my residents and my fellows that you should do everything twice as much for the uveitis patients. So you see them twice as often, you treat them for twice as long, and twice as much therapy during that time. In terms of what procedure to use, I'll leave that to my glaucoma colleagues. So this is my colleague, Dr. Tang. That's basically Alice in Wonderland is expressing my feeling of like, what do I do in terms of the procedure? So I would just ask Dr. Tang at that time. In addition, there's also a question sometimes about what procedure or whether patients need 2 procedures at once. I always think it's better to keep things simple if possible, but sometimes you need to do 2 procedures. So this was a patient who I had just coming out of fellowship who had sarcoidosis. She had this previous sort of scleral melt, which resulted in this uveal show, which was conjunctivalized. But if you look here at her optic nerve, she's fairly cupped and her pressures were not controlled. She needed a glaucoma procedure. And so the question was what to do. What we ended up doing was actually closing the inferior uveal prolapse or covering that with a scleral patch and actually opening it up and doing a trachelectomy on the superior conch. And she did quite well. So again, the key points here, we always want to refer to our glaucoma colleagues early. Get them involved, the earlier the better. Be generous with your use of corticosteroids during this time. You really shouldn't hold back, and as I said, double the amount of what you would normally do for your other routine patients. Try to establish a uveitis diagnosis. Definitely try to get these patients testing. I know from my experience here now at Nepal, it's not always easy to get a lot of those tests. At the very least, try to get testing for syphilis and try to get testing for tuberculosis. The other tests, you know, if it's not infectious, then the other tests, the treatment for everything else is going to be steroids typically or immunomodulatory therapy if that's not working. And lastly, do only as much surgery as is necessary. So, even if the patient has a cataract and needs a tube, try to just do the tube at that time, get the patient stabilized, and do the cataract at a later date. So I want to thank you again for your attention and the opportunity to speak today. Thank you.
Thank you, Dr. Sanjay, for enlightening presentation. I would like to take this opportunity to express my sincere gratitude for your valuable guidance and teaching in this short period. Your expertise has greatly enriched our time together. If you have any queries regarding the previous presentation, the floor is now open for discussion. It is our privilege to express our gratitude to all the experts for ORS team. Your insights have truly enriched our gathering and made it fruitful. Now we are distributing token of appreciation to all the speaker, which will be followed by group photograph. May I kindly request Dr. Jeevan sir to present token of appreciation to Dr. Ronald. Jeevan sir, please. Thank you, sir. May I kindly request Thank you, Jeevan sir and Dr. Runal. May I kindly request Dr. Sanjay Singh sir to present token of appreciation to Dr. Sanjay Kedar.
Now I would like to request Dr. Indira Paudel Bam, President of Glaucoma Society of Nepal, to present the token of appreciation to Dr. Christopher. May I kindly request Dr. Rohit Saiju sir, an expert oculoplasty surgeon of Nepal, to present the token of appreciation to Dr. Omar. Now we'll be having a group photograph on the stage. All the speakers